Hello everyone. Columbia Global Centers Mumbai and Columbia Global Centers Nairobi welcome you to the second part of our webinar entitled Oral Health and Healthcare During COVID-19, Lessons from India, Kenya and the United States. Remote Learning and Training for Dentists and Dental Students. I would now request Dr. Ravina Agarwal, Director, Columbia Global Centers Mumbai, to please start the session.
Hello, everybody. On behalf of the network of the 9 Columbia Global Centers worldwide, and the initiative taken by Columbia Global Centers Mumbai and Nairobi in partnership with the Columbia School of Dental Medicine, I welcome you to the second part of this two-part webinar series, Oral Health and Healthcare During COVID-19, Lessons Learned from India, Kenya, and the United States. A word about the Global Centers. The Global Centers were established over a decade ago and with the mission to promote global learning and knowledge exchange to be able to address and answer some of the most challenging issues pressing our world in the 21st century. And we believe that, as an educational institution, Columbia University has a lot of expertise and knowledge and has a lot of learning from different regions of the world to do as well. And partnerships that we build and exchanges that we have and dialogues that we deepen globally can all help us to understand the world better and to make it a better place. The COVID-19 pandemic has caused many difficulties in providing elective and non-elective dental care to patients worldwide. Last week, we learned about the different approaches undertaken by dental facilities in India, Kenya, and the United States to screen patients, resume dental services, and provide dental care to patients in times of this pandemic. In today's session, entitled Remote Learning and Training for Dentists and Dental Students, but we will add to the dialogue on clinical and community care and talk now about the importance of distant learning and discuss some of the innovative practices dental schools across these regions have resorted to provide virtual dental training and community outreach services during this pandemic. We will learn how the opportunities present that dental educators have are really good in terms of modernizing their approaches to deliver appropriate pedagogy using digital concepts, enhancing online communication through different learning platforms, and utilizing online media for teleconsultation services. So education has new challenges and new opportunities, and dental schools are seizing some of these opportunities and are learning from each other, and as is our own Columbia University School of Dental Medicine. To begin today's session, I would like to call upon our moderator, the inspiring and passionate Dr. Kavita Ahluwalia, who's the Associate Professor of Dental Medicine and the Postdoctoral Program Director of Dental Public Health at the College of Dental Medicine at Columbia University. So welcome, Professor Ahluwalia.
Thank you, Ravina, and that was a lovely introduction to our seminar series. I'd just like to thank both the CGC Mumbai and the CGC Nairobi for being such great friends of oral health and for always supporting oral health. We've done a lot of work with them over the past 6 years. To our audience, welcome to part 2 of this two-part series. As Ravina mentioned, last week we talked about how dental offices and dental systems are gearing up to provide dental services, and how that has created so many problems at community levels because policymakers sort of put a stop to services during the pandemic. In New York, we are beginning to open up again. Private dentists are open and health systems are open. But today we'll hear about how dental schools have pivoted towards using online training methods to train their students. And while this has provided many opportunities, both for students and educators, it's also brought forth some problems around clinical training and evaluation, which must be done in the clinic and must be experiential to be meaningful. Today we will hear from the United States and Kenya about the training of dentists and dentists in training. We will also hear from a large public hospital in New York City about the experiences of dentists in training at the front lines during the pandemic. And we will hear about an innovation community education project mounted in New Delhi, India. I'd now like to invite Dr. James Fine, Professor and Senior Academic Dean for Postdoctoral Programs at Columbia University College of Dental Medicine, to talk about the training of postdoctoral students and dentists at Columbia University.
Good afternoon, good morning. I'm honored to be part of this Global Center program with other fantastic educators throughout the globe. One of the things with this pandemic was not that we were just going to look at trying to create a new paradigm for our education, but we needed to know that we needed to train and educate our residents, postgraduate students, and faculty providers for not just the future, but managing this present pandemic and any potential resurgence or second wave of the virus. What distinguishes these three groups? And we consider at Columbia University, residents are assigned to the hospital. Our hospital is New York Presbyterian Hospital, one of the most significant hospitals in the United States, consistently ranked in the top 10, a very sophisticated tertiary medical center. The residents are also assigned to the dental school. Our postgraduate students are assigned to the dental school, and our faculty can be assigned both to the hospital and to the dental school. We also don't take education here and training to just be something for our students and our residents, but ongoing, constant faculty development is just as important, and we put a huge amount of effort and a lot of energy and sophistication into making sure our faculty are constantly developing and are doing cutting-edge dentistry. For our residents under the supervision of faculty treated both outpatients and inpatients for dental emergencies during the height of the pandemic. So although, as many of our speakers last week have pointed out, in the state of New York, we had stopped anything but dealing with dental emergencies for about 15 weeks. The emergency clinics and actually direct patient care had to be ongoing, consistent, and much of it was provided by our hospital dental residents. So 3 groups that we wanted to, as I said, provide education. So there are residents assigned to the hospital, New York Presbyterian, and to the dental school, our postgraduate students assigned to the dental school, and our faculty assigned both to the hospital and the dental school. Our residents always function under supervision of faculty, and as I said, treated both outpatient and inpatient. Okay. What were our key educational focus for our particular residents? 1, managing pain. And this was extremely important during these 15 weeks for most of the patients presenting to the emergency clinic had pain. 2, managing infection. 3, actually practicing infection control at the highest level. And finally, identifying patients potentially at risk for COVID-19 virus. The faculty also treated patients and supervised residents, so that the faculty had to step in where our dental students were no longer on the premises and help handle the volume of emergencies that were coming through. And they treated both outpatient and inpatients for these dental emergencies. We wanted to look at key educational components of the faculty, and every single evening we would meet with the faculty via distance learning techniques such as using Zoom to go back over how they were managing pain, how they were managing infection, how they were practicing their infection control, and how they were deciding who was potentially a patient who could be COVID-19 positive. And these are important things because as the information from the CDC, the World Health Organization, and from our own New York State Department of Health kept on updating us on how the virus was presenting itself, the comorbidities and the other situations associated with this virus, it required constantly updating the faculty on new measures of infection control to keep themselves safe and other patients safe, and potentially managing patients who were infected from the virus. Our postgraduate students, they did not provide direct patient care, but they did manage their patient rosters, which is their student practices, to identify those needing potential urgent care for referral to the emergency dental clinic. And this was very important. We wanted to make sure that we stayed in front of any potential dental emergencies and minimize it. So the students, both graduate and pre-doctoral education students, were constantly in contact with their patients, checking to make sure that no untoward oral health problems were developing. And if they were, to make a timely referral to the emergency dental care clinic. There were key educational components. So through this devastating pandemic, we wanted to also make sure that there was ongoing education that was both keeping their current course of study going and also educating them how to manage COVID-19 patients. So we continued all educational courses via Zoom. We continued master's research project with mentors via Zoom. Our students participated in lectures with students from other national and international universities. The remarkable thing here is it actually opened the walls and the silos, so to speak, inside many universities in the United States and around the globe. That once we went to Zoom as a platform for doing distance learning, many more institutions could share with each other's knowledge and skills and abilities from their respective faculty and their students. Now, during this whole time, we also had to have preparation for return to patient care. We had to take our students and those faculty who were not here on premises to be ready when they do come back and they interact with patients. So review principles of physical diagnosis, better understanding of how to maintain infection control during the pandemic, and especially important, wearing the N95 respirators. As you're all aware, one of the things to keep your staff and faculty and your providers safe was the ability to properly have access and wear an N95 mask to keep this respiratory virus from infecting large parts of your students, staff, and faculty, and thereby creating a whole series of other problems. The physical diagnosis part is, once again, being able to take a better medical history that would tell you who potentially could be infected with the COVID-19 virus. So we had these constant debriefings that went on a daily basis. We went and we self-reflected ourselves on what we were doing, whether we were doing it properly on both patient care level, the education level, and our future ability to manage the next wave, if it does come, of the pandemic. We had made a conscious decision that we wanted to manage patients without opioid pain medication. One of the things that many of the states and governors became concerned with, that once they shut down dentistry from doing routine dental care, would there be an over-prescribing of opioid pain medications. The United States has been in the middle of an opioid pain medication crisis for the last several years. So we didn't want, so just having taken control of that, the states did not want to create a secondary problem with opioid pain medication. Next, manage infections without overprescribing antibiotics. And to develop drug resistance to various bacteria, once again, by overprescribing antibiotics, was another situation that you did not want to create as a complication. We also understood that we had to establish drainage of the infection if required, even that you didn't want to shy away from actually doing something intraoperatively on those particular patients. And we did want to make sure we learned how to limit the use of aerosol-producing equipment, but if required, we could do it in such a way to both be safe when it was utilized to both adjacent patients, staff, and the faculty involved. We want to engage the patients to understand that the limited treatment is also to protect themselves and their family from the virus. That the patients, when they came in, needed to be counseled that many things that we were or were not going to do was for their own benefit and for the family's benefit, to not allow this virus to further spread. We wanted to make sure also to give a patient a proper diagnosis. So we did spend time taking the appropriate radiographs and sitting down with the patient to actually educate and inform them, why are they in pain? When is the pain going to end? And how we're actually going to manage that pain. And we also wanted the patients who did come into the emergency clinics to be given an action plan for their oral health care to be started once the COVID-19 pandemic is controlled. And this many times was done through teledentistry. It was done remotely. It was done over the phone. It was done via Zoom and so on, that we wanted to make sure that the patients understood what they would need to do to have optimal oral health care once everything settled down and the need to come back to the dentist. Students and residents and faculty can receive quality education through distance learning using technologies like Zoom, provided the instruction is focused and organized. And one of the things about Zoom is that, as many of you have used it, if there was not structure, even if you had a small group of 6 to 12 residents, students, or other faculty, a lot of information would be basically lost. So it actually forced the faculty members to go back and make sure that they were focused and organized during those Zoom lectures, and it wasn't just an open-ended conversation. Distance or remote education probably needs to be more structured than in-person seminars. And as we would debrief our faculty how it was going, this became quite obvious that without the participants in the room, you needed to be clear where you were going with your seminar, what directions were you trying to actually provide the individuals who were taking the course or the seminar. Self-reflection time, we felt, is necessary for the students and the faculty. One of the things what we didn't want to have is 24/7 Zoom. Something that became quite easy, that with many of our faculty, residents, students, and graduate students having gone back home throughout the whole world, it became easy to just have nonstop Zoom. But you need time for these individuals who have been taking this stuff to go back and self-reflect on what they've been learning. It also gave us an opportunity that self-directed education now more than ever needs to be supported. Many of our students and our residents and faculty are extremely bright and capable of actually ascertaining information, if given in the right direction, to have self-directed education. Team teaching is important with distance learning, and Zoom can have multiple educators providing the content. So many times what we felt was that this now allowed, where we would only have in the past one faculty member show up to an auditorium, or to a seminar room. Now we can take advantage of many thought leaders actually interacting together for the students, residents, and other faculty who we were training, so that team teaching creates, if done correctly, provides a synergy and a major improvement, something that scheduling wise was not easily done in person. Learning objectives should always be presented so that those who are coming in to the presentation are clear about what they will be taught, what they should go back and self-reflect on, and what they can further have self-directed learning to actually learn more in depth. Post-lecture or course evaluation should be performed to assure command of the information. It can be oral or written. The fact that no one is on site and that they're doing distance learning does not mean that you don't have to see if the information was actually properly presented and properly absorbed or retained by the individuals on the other end of the distance learning. Outcomes. What are the outcomes when we've looked at what has transpired since March through the end of June in the United States, especially here in the state of New York at New York Presbyterian Hospital and Columbia University? Our outcomes for us were A, to provide safe environment for oral healthcare providers and staff. And this goes back to what we originally talked about on the parts of infection control and identifying those individuals potentially who are COVID-19 positive. Provide a safe environment for education and learning, that there were places for those residents who had to come into the building would be able to go on to a distance learning Zoom session with social distancing and safety. And you have to keep everyone healthy, both mentally and physically. So even if the graduate students were not present, the stresses on them of wondering when their education is going to be reestablished in a formal way, whether they're going to learn the right things and whether their career is going to continue in the proper direction. This has incredible mental stress and physical stress on those particular individuals. And this has to constantly be focused on. Well, I thank everyone for their attention this morning. And as Kavita's pointed out, you can ask questions via chat. Thank you.
Thank you, Dr. Fine. That was a very thought-provoking talk, and I noticed that there are quite a number of educators as well as students who are participating in this session, and I'm very hopeful that we will get some interesting questions for your attention. Next, I would like to invite Dr. Regina Mutavi, who is the Dean of the University of Nairobi School of Dental Sciences. She will discuss undergraduate training as well as some graduate training during the COVID pandemic. Dr. Mutavi?
Thank you, Kavita. Today I'm basically sharing a little from the training of healthcare workers in Kenya during this pandemic. And a little deviation from what we discussed last week, which covered a lot of the dental training. And so as a way of introduction, I needed to say that, you know, Kenya is a lower middle income country with a population of 47.6 million. That was according to the census undertaken last year, with about 72.5% of this population in the rural areas. Since 2010, Kenya has a devolved healthcare system with 47 devolved units managing healthcare together with the national government. And I just needed to highlight the issue around budgeting, that the national government has allocated about 4% of the total budget, while it's expected that the counties, the 47 devolved units would also be able to allocate some money for dental, for healthcare. I need to mention that there's not a very direct allocation that goes to dental health services. And yes, the training of dentists in Kenya began in 1974. And to date, there are about 1,443 dentists that have been registered through the Kenya Medical Practitioners and Dentists Council. Of course, this is since inception of the registration process. And looking at the records in the Kenya Medical Practitioners and Dentists Council revealed about 762 who are actively retained. And from previous records, we know about 80% of these dentists are in urban centers. The School of Dental Sciences, which is where we are, trains about 30 undergraduate Bachelor of Dental Surgery students every year, and has serious limitations of infrastructure and staff. And as I probably shared last week, that with COVID-19, this number is likely to be pushed lower down because there is the requirement for personal protective equipment to make sure that there is protection of the dentists, the trainees and faculty. There's additional safety measures in the clinical setting that presents a serious challenge for this particular approach of training. And the School of Dental Sciences has trained about 80% of the dentists practicing in Kenya. So when I talk about the capacity is likely to be reduced further, it means that we could be having fewer and fewer graduating dentists in Kenya. So I'm talking about this because when you look at the numbers of dentists in Kenya vis-a-vis the population, you realize that the dentist to population ratio for the all registered dentists, whether they are in Kenya or they have left practice, translates to about 1 dentist for 33,000 in the population. Whereas if you actually look at the active dentists, then you realize it's somewhere in the tune of 1 dentist for 62,000 in the population. I just wanted to compare that with what was a situation in California in 2012, that you had about 3.9 dentists per 5,000 population. And that tells you how far the country has got to go in training the dental workforce, even after COVID has checked in and reduced really what we can and cannot do in the training of dentists. The oral disease burden in Kenya remains that, yes, for the children under aged 5 years, we have almost half of them reporting dental caries. Of course, when you have the combined child population, at least 2 out of every 10 children have dental caries, and for the adults as well, you can see that. What is important to note is that it does look like dental services are not really accessible, because almost half of the children have never visited a dentist. And in the 2015 Kenya National Oral Health Survey, at least about 1/3 of the adults that were surveyed seemed to require an urgent intervention for pain or infection management. Yet there could be a lot of issues affecting access, including the fact that only about 1 in 10 of the population has access to any form of dental insurance cover. And we also seem to be having an increasing experience of dental fluorosis in the country. So this is a disease burden which is quite heavy. and the dentist population isn't growing at a rate that could definitely be able to bridge this gap. So what I am sharing with us today is a strategy that is training for prevention of oral diseases, which we consider is likely to help assist the situation going forward. So the School of Dental Sciences at some point a few years ago considered utilization of non-oral health personnel for prevention. And we managed to get to train the final year medical students a bit in a very short course that is taught to the graduating class. And the highlight is the fact that the final graduating medical year students normally number about 300 every year. And of course, in 6 years, you could easily have graduated 1,800 students, which is far higher than the number of dentists that we have achieved so far since 1974. And the faculty deliver lectures on common dental diseases and conditions. And during the COVID-19, online teaching has been going on. And in fact, a course evaluation was done during the COVID-19 era. And each student in the final year medical class gets to rotate at the dental clinics of the School of Dental Sciences for at least 1 week. That is the time that we have allocated for now, and we try to utilize that time as much as is possible. The objectives of this course is really hinged on the fact that there are more medical officers deployed across the healthcare system compared to dentists. And so this strategy is supposed to create awareness of common oral diseases and conditions in the medical, in the graduating medical students. That would be able to at least promote prompt referral of serious diseases with oral, conditions, and build some strong teams for multidisciplinary approach. And of course, we hope in the long term, it could be able to promote community prevention strategies, because if every medical student we train is able to reach out to their community, and of course also advocate for oral health. And so we got a little bit of feedback from the group that we are currently training. And one of the questions that we try to find out from them is how they intend to utilize the knowledge they are acquiring from the oral health training. And a lot of them said yes, at least 58.6 thought the knowledge was highly educative and they were going to use it on their patients as they practice medicine in the future. And again, another 61% thought it was good knowledge and they were going to share with their patients as they go forward. Obviously, we are yet to see and maybe survey those who are in practice and see how well they are utilizing the knowledge that we are passing on to them. But there were also a lot of other interesting comments from them, because one student thought that I think this course should start earlier, maybe in their 4th year, so that they could have more details in their 6th year, because they do have community. It would also help with health education during the community health rotation in 5th year if medical students have some basic understanding in oral health. The students do a community health rotation. And so what the student is saying is basically the school should consider getting an earlier slot to teach them, so that as they go out to do their community health rotation, they would be well versed with dental diseases and they would be able to educate. Of course, others talked about the delivery of the course, that lecturers should consider the use of animations or videos within presentations to supplement verbal explanations for more complex concepts, Remember, these are final year students and they haven't had prior exposure to any training in dentistry. And a few students thought we should increase the rotation time, and the 1 week rotation was too short. And one student was very impressed that our lecturer sat them down to explain simple details of teeth and important things they should tell mothers who visit with their children. And they felt that was the best from this particular rotation. The highlights are that the medical students seem to be grasping a lot from the dentistry course, and the fact that COVID is now presenting a situation where our dental schools may not train more dentists as we would like. So this is the second group we have trained, and we hope the feedback will be able to improve the course delivery and the content, and going forward it will shape the way we train these medical students. I want to thank you very much for listening.
Thank you, Dr. Mutavi. That was an amazing presentation. I know that in the United States, we are working quite hard to try to integrate dental and medical education, but I don't think we have gotten as far as you, and we certainly have not got medical practitioners to say that they would like more time and more rotations. So kudos, and we look forward to hearing more about your program in the question and answer session. I'd like to invite Dr. Victor Badner now, who is the chair of the Department of Dentistry at Jacobi Medical Center, part of the North Central Bronx Hospital. He is also an associate professor at the Albert Einstein College of Dental Medicine, and he will lead us through what his program's residents felt about being at the front lines during the COVID pandemic. Dr. Badner.
So first of all, thank you very much for the opportunity to participate today. Dr. Mutavi just spoke about how medical personnel can assist in oral health care delivery and in oral health care. I'm going to speak about how oral health care personnel or dental personnel were instrumental in assisting their medical personnel during the pandemic in the Bronx. The way this talk is structured is that I'll give you some background about where we are. I will talk about the specific activities that we participated in, and then we'll discuss some outcomes. So to give you some sense of the environment, Jacobi Medical Center is located in the Bronx, New York, and the population of this county, one of the 5 boroughs of New York, is 1.4 million people. It's extremely ethnically and linguistically diverse, with about 192 different languages spoken within one county. The Bronx is known for having dense and poor housing, vast swaths of poverty, and really domestic crowding wherever you may be. New York State ranks the counties within it based on health outcomes, and the Bronx, before COVID, was 60th out of all 60 states. That's the worst county in health outcomes, not oral health outcomes, health outcomes in New York State. And by the end of May, the Bronx was acknowledged to be the county having the highest prevalence of COVID-19 infected individuals in New York State, with approximately 38 to 51% of the population surrounding the hospital in the Bronx testing positive for antibodies. And the local area around Jacobi Medical Center had one of the highest hospitalization rates in the United States. This is not a competition for who gets to hospitalize more people, but I'm just trying to give you a background of how serious and how prevalent the infection was in our area. The hospital, Jacobi Medical Center, is part of the municipal hospital system of the City of New York. The municipal hospital system of the City of New York is the safety net hospital system for patients who are indigent and underserved, and the motto of the entire system is, we take care of patients regardless of their ability to pay. Those not in the United States would recognize that the U.S. healthcare system is not nationalized, and there are many people without insurance and having low access to care on the medical side. let alone the dental side, which is even worse. The hospital is a 450-bed with 54 ICU beds institution and a level 1 trauma center, which means that it takes care of trauma that's motor vehicle accidents, gunshot wounds, or knifings, or any kind of trauma of all kinds for the area. But we are also a major teaching hospital for the Albert Einstein College of Medicine, and we have postgraduate medical and dental residents. The Department of Dentistry serves the ambulatory and the inpatient needs of the patients presenting for care, as well as doing outreach in different clinics and community centers to try to increase oral health activities and oral health literacy. The department has 53 residents in training in 5 different training programs: general practice, pediatric dentistry, dental anesthesia, oral and maxillofacial surgery, dental public health, and we have a fellowship in craniofacial orthodontics. We have full and part-time attending dentists, as well as per diem dentists and per diem hygienists, and part-time and full-time hygienists. In addition, we have assistants, clerical staff, nurses, administrative personnel, for a total support staff and a total staff of approximately 120 people. So let's go and give a little timeline of what was going on, and this will tell you where we were. So back in March, the governor of New York signed an executive order calling the pandemic a disaster emergency in New York State. And about the same time, the World Health Organization defined the COVID-19 outbreak as a pandemic. A week later or so, the governor announced that New York State would limit all outpatient surgery and would limit dentistry to urgent and emergency care only. The call went out from the governor to see if there were medical personnel, that's retired physicians or dentists, anybody who could help, because we were being swamped by the need of COVID-19 infected patients for health care. That week, we obviously were beginning to see only emergent and urgent cases, and the hospital was becoming overwhelmed with COVID-19 patients. At that time, our chief executive officer, our chief medical officer, the chairs of medicine, surgery, and emergency departments called out to their colleagues within the institution for help, because they realized they could not handle the onslaught of patients that were coming in with COVID-19 who needed to be cared for. We, as a Department of Dentistry, responded, and we also, at the hospital, received 122 Armed Forces Medical Reserve Corps members in the first week of April. So that meant that we were really calling out from wherever to get help, because we were overwhelmed and needed more workforce to take care of the patients. So what was our general approach in trying to respond as a dental department to the pandemic? So there is an old Jewish proverb that says, "If I am not for myself, who will be for me? But if I am only for myself, what good am I? And if not now, when?" I took that proverb and basically applied it to the situation. I said and told everyone and wrote an article that was published in the New York State Dental Journal that said, first and foremost, you must have personal safety. So we said that we needed the personal protective equipment in order to feel that we could do anything else except to protect ourselves during the pandemic. But if you had that PPE, then the next phase was not to hide in the corner with the PPE, but to use it as a healthcare worker to help others. And in a situation like this, how could you not come forward now when we were really needed? So it was about personal safety and then patient care and service. But as Dr. Fine mentioned, there was a real concern around psychological support. That we knew that the dental healthcare workforce was not familiar with dealing with life and death situations and really, really sick patients. There is a program at Jacobi Medical Center and in the municipal system in New York called Helping Healers Heal. That's when medical or dental providers have struggles psychologically with their patient care, and we try to help the healers take care of themselves. The same was true here, where support was given and offered ahead of time, as well as throughout our efforts to prevent and to deal with PTSD and the difficult things that people were dealing with. And the general philosophy that we had was we would identify our roles and we'd each step up one level. So what we first did was we did training. We had front desk trained, who were front desk people at the dental facility, were trained to deal with being front desk people at the medical units. With the dental department quite shut down, we transferred them and deployed our front desk people to medical units to deal with the patients that were coming in and being transferred there. We also taught them how to do donning and doffing supervision, something I will get into more in a little bit. Dental assistants were asked to step up. They were trained as phlebotomists and also were trained to be supervisors of the PPE acquisition and removal. But they were readily willing and able to become phlebotomists, and they did step up to do that. Pediatric dental residents who have a requirement in their residency program to do research were trained to work with research units on different pandemic-related therapeutics, including remdesivir and cerulumab. General practice residents who have training in oral and maxillofacial surgery did their simple oral surgery with an attending present and with supervision, but they were asked to do more than they might have otherwise. And our oral and maxillofacial surgery residents were moved to the general surgery units and took care of critical care units as well as general surgery patients, because that allowed their general surgery colleagues to take care of COVID patients. But our most exemplary residents were our dental anesthesia residents, who were the only anesthesia residents in our institution, but they were trained and supervised in critical care and care of intubated patients in medical ICUs. This is the range of activities that we did. We did off-site work, including research and contact tracing and triage calls. We did inpatient support services. We did specialized COVID care, such as the general surgery unit I mentioned, and our step-down ICU that our dental anesthesia residents. And we also were the only service taking care of our maxillofacial trauma. It used to be shared with plastic surgery and otolaryngology, but we took all of it, and we performed the drive-through testing that occurred at our institution. The donning and doffing, as you can see, as you can just imagine, the PPE is there to protect the individual from exposure, but it has to be done in an appropriate way. The mask has to be fitted. It has to be done so that there's a good seal. People have to be taught how to do that, and they have to be supervised as they're putting it on. But even more important, they have to be supervised as they're taking it off, because they could contaminate services, could contaminate their colleagues, and they were supervised and watched as they were doing this, and that's what some of our ancillary personnel did. This is some of the activities that you see our dental anesthesia residents and our oral surgery residents doing. This gentleman is our senior resident in oral and maxillofacial surgery, and he performed the first and drive-through testing that was done, where he did nasopharyngeal swabs of people that would come in their car, and he would be suited up to do this in order to get testing that was performed on people who wanted to know their status. Our dental anesthesia residents got all dressed up in hazmat-like suits to reduce and completely eliminate exposures for those patients who were intubated and quite sick. There was a lot of studying going on, and people were learning their algorithms and learning what they needed to do with supervision of some of our attendings. But they did support each other emotionally as well, as they tried to put on a good face during a very difficult time. We did, as Dr. Fine said, deal with the idea of doing reflections. So we asked people to tell us about how they were doing. We had a reflection from our director of the surgical ICU, Dr. Mel Stone, who basically said that the dental anesthesia residents cared for the sickest intubated patients infected with COVID-19, and the dental anesthesia residents were required to be patient advocates in regard to end-of-life and palliative care issues after having learned critical care algorithms, and they were, in fact, integral, needed, and excellent in all aspects of patient care and really helped their colleagues. The dental anesthesia residents themselves did reflections so that they could process the difficulties and the difficult times that they were facing. They talked about that I was in the unit every single day, and when they weren't there, they were thinking about their patients all over the world and dreaming about them. They actually recognized that while some patients passed away, They actually helped to celebrate those who were able to walk out. Another resident said, "I'm there for the families." To share the distressing news that a loved one has passed away was very difficult for dental residents who were not trained to do this, but they stepped up admirably, and we supported them as they did this. Because we were concerned about how the staff was doing, we did a staff survey in June, and we got a 2/3 response rate, which was quite impressive in a time like this. We asked them whether or not they had come down with COVID-like symptoms, and 20% of our staff said they had. Now remember, we don't know if that's a high number or a low number, because remember, 40% of the population around them were positive, and that was community spread. We have no documented cases of anyone getting the virus from the work that they had done, and we were lucky enough to know that nobody who became infected of that 20% was ever seriously ill, hospitalized, or intubated, and thank God no one passed away. We did ask them how they were doing and whether they feared becoming infected at work, and 88% people were afraid. They strongly agreed to that statement, but 85% believed that they got the PPE they needed, and only 1% or almost 2% said that they disagreed with that. They were proud of the work that we had done, but as you'll see from the last two questions, there's some work that needs to be done if we're going to move dental personnel into medical areas, because sometimes they did not feel like they were appreciated or really were needed, and felt that they were not accepted so readily. So there's work. It's not a complete wonderful story. There's still some work that needs to be done to improve that idea. But the outcomes of what we've done are listed here. In March, from March to June, we had 1,255 COVID-19 positive patients, of which 319 succumbed. There were even twice as many visits related to COVID-19, so we were working very hard. Many of the members of our medical staff were redeployed, not just dental, but other departments also were redeployed. They expanded the medical staff by 25%. They increased the inpatient beds by 150 beds. They doubled the ICU capacity, even though we were at maximum of 54. We got over 100 at the end as they changed other units into ICU units. During the month of April, the Department of Dentistry provided 361 emergency visits. We were open for that, and that was what was to relief of pain and to take care of emergencies. It should be noted that 361 represented an 88% reduction from the number of visits we had provided the previous April before COVID. The thing that we are most proud of is how our dental anesthesia and oral and maxillofacial surgery residents worked with their colleagues, earned the respect with their colleagues, worked tirelessly, providing 300 12-hour shifts on ICU and inpatient wards to try to help their colleagues and support the effort at our institution to deal with the pandemic. The education that was provided by our attendings in dentistry as well as other specialties really helped them to become part of that team and to feel competent and not overwhelmed during this difficult time. And we are very, very proud of that. And we wanted to make sure that they recognize that dentists in training provided versatile, trainable, and team players during a very necessary time. And in fact, if in fact it ever comes again or it continues, expanding the scope of practice for dental healthcare workers to help their medical colleagues during a national and global pandemic or global needs, but particularly during emergencies, should be considered, as we were able to do it here. Thank you very much for your time. I really do appreciate it, and thanks to be part of this wonderful panel.
Thank you, Dr. Banner. That was a very inspiring talk, and wonderful to hear how dentists stepped up and really worked very tirelessly during the pandemic. I'd like now to invite our final speaker, Dr. Vikrant Mohanty, who is an associate professor and head of dental public health at Maulana Azad Institute of Dental Sciences in New Delhi. Mohanty has been running a number of community-based programs before the pandemic, but we'll discuss one particular program that was put in place during the pandemic to continue to educate the community around oral health prevention. Dr. Mohanty.
Thank you so much. They say that change does not roll on the wheels of inevitability, but comes through continuous struggle. During these testing times, when we look back, as we move forward, there's a lot to learn from the perseverance, patience, and grit that mankind has shown over the time. It has not only allowed us to overcome this through struggle, but also march ahead. Good morning, good afternoon, good evening, ladies and gentlemen, and dear colleagues. It is a great honor and pleasure to be around with all of you. And we have realized in the last 3 to 4 months that how much we needed appropriate healthcare systems, health human resources, and technology, which has changed our life over the time. Today, I'm here to share with you the community outreach program that we have developed here in our Dental Institute in India, New Delhi. And as I take you through this journey, this is the institute where I work. Uh, this institute actually is the only dental hospital which has been responsible for dental services for more than all the population across Delhi. And we have been providing emergency and urgent services and also dental education through the online medium, which many of us have been doing. So my presentation will mainly talk about the various, we'll be going through the response that India has done to COVID-19. Just to say a slide, a little bit on the oral health burden of oral disease burden in the country, and then moving on to what our institution has, how it has responded during this COVID-19 times, and moving on to the main, part of the presentation where I would be focusing on the various community outreach components of the Dental Institute. So India currently is number 2 when it comes to the COVID-19 number of cases. You see from this slide that there are almost 390,000 active cases, but we also need to see at the green, tile, which talks about almost 7 lakh patients being cured. Delhi, that is where I stay, nearly 1,22,000 of them have been infected. But there's a positive sign is that the cure rate is almost 62.6%, and the total number of sampling, as you see, has gone very high. We are the second country in the world to have tested these many numbers. So what has been India's response, and why has been, there has been so much of hue and cry of COVID-19 across the world, but India being one of the largest democracies with such huge, almost 1.38 billion population, has actually responded well to COVID-19 only because of few stringent and strong strategies by the government. Early lockdown, large-scale COVID testing, healthcare infrastructure being developed, health human resource put to task. India is one of the few countries where vaccine development has reached the stage 2, and massive health promotion and awareness campaigns and availability of PPE, there has been a huge hue and cry about availability, but India has never not faced that. When it comes to the burden of dental diseases in India, uh, yes, the scenario is totally a stark difference, that there has been huge burden of dental caries and periodontal disease affecting almost 90% of the population. Oral cancer, yes, India does figure in the top 5 countries across the globe with oral cancer and pre-cancer, and other dental diseases which are still, there's a huge maldistribution of these diseases, because mainly the population in the rural areas is almost 68 to 70%, as compared to urban population where most number of healthcare providers are actually located. So when we look at the institution's response, that is MAID's Maulana Azad Institute of Dental Sciences response, we started off by providing mainly pre-screening strategy almost way back on 18th of March to 2020, when the world was just gearing up to respond to the outbreak of COVID, which was declared on 12th of March. So over the last 100 days, we have screened more than 7,500 patients and treated nearly 42% of them by providing some form of emergency or urgent, comprehensive care. Through these pictures, you can actually see how the triaging, how the screening, and how the treatment and training also of our various healthcare workers and non-healthcare workers has been carried out. So moving on to mainly the community outreach and tobacco cessation services that we have strengthened during this COVID time to continue not only providing services, but also continue to promote oral health through innovation and outreach. So when we talked about tobacco cessation clinic, which I will just briefly be explaining a bit of it, wherein we started this cessation clinic way back in 2011 and have been instrumental in providing services for more than 6,500 patients over the years with very strong follow-up strategy. We have now been identified as a national resource center for oral health and tobacco cessation. We have used many platforms and channels to actually provide these services. But during COVID-19, the government of India took a very strong step wherein they actually banned the use of tobacco across the country. That means with the last survey, we had around 266 million people using tobacco. In one shot, the whole of India had a lockdown, not only on the population activities, but also on tobacco use. So that put a huge burden not only on mainly on the users, but also it gave a window of opportunity for healthcare providers to reach out to these users. So we used the opportunity, and we almost we took out the numbers of 300 patients in the last 3 months who had registered with us. We used a very strong protocol that was developed, and a very simple strategy to reach out to these patients. One of our faculties, Dr. Weber, was responsible for actually interacting with these patients and following up with them. And we used a simple algorithm wherein we really looked at what could be their current status and how they intend to continue or discontinue the habit, and coping strategies, mechanisms were provided to them. We also checked with them if they had any dental problems. So the results were very promising. We had a self-reported quit status of almost 52.7%, and that was actually much higher than national average. So this basically gave us an insight that such kind of strategies can actually yield a lot of results. So we didn't stop there. We went on to develop, because mainly the resources have been a constraint during this time. We actually made an effort to utilize whatever was available. We came up with these, health awareness posters and social media campaigns wherein we promoted oral health, tobacco cessation through different ways. This particular posters, which are developed by our students, mainly focused on how spitting, prevention of spitting in public places would yield in, breaking the chain of transmission of COVID-19. We also went on to develop some health awareness movie. This movie, you can see that, with whatever resources available and the staff available, we utilized and developed very simple, very catchy health awareness, movies. Also, we have been working on this particular aspect of developing comics, and this particular time which COVID-19 gave us, we strengthened our efforts, and the professional artists in our institute went on to develop 3 comics which have been currently under validation process through school teachers. These comics are targeting mainly school children, and the intention is to promote oral health and reduce tobacco use among these children. So the validation process is almost completed for almost 150 teachers. We have been using the patient education material assessment tool, the PMAT, for these through the help of school teachers, so that we can validate it and then implement it among school children. The institute has also been involved in developing training manuals at various fronts. So moving on to the main component of the presentation, that was mainly on the teacher training program at school level through a virtual platform. I would first start about where exactly this program actually started. So this is the first program in India, which is known as the Mobile Dental Clinic Project, which started way back in 2014 with the implementation of 6 mobile dental clinics with 28 staff, whose main focus was to reach out to the communities in far-flung areas of Delhi and provide preventive, promotive, and curative services. Till date, over these last 6 years, the team has been tirelessly working and has rendered services to more than 2 lakh plus patients and treated almost 62% of them. We've also been expanding these services not only to curative services, but promotive and preventive services. As a result of which, one of our mainstay of our efforts is capacity building. We have almost trained 4,700 health workers who are involved in maternal child health, and we have integrated oral health into maternal child health. We've also gone on to target different specific, risk groups, like mainly children with special needs as well as elderly patients. So we have targeted through these kind of strategies, and we have covered more than 30,000 miles with these mobile clinics. So from there on, we went on to also work on this particular project, which is the project NEEV. NEEV means the foundation. NEEV is a Hindi word, and it means foundation. So the foundation of oral health needs to be instilled early. Any healthy or positive behavior needs to be instilled healthy in a child's life. So this project NEEV was mainly to target the school children, and we targeted the government or the public health, the public schools, that is the government schools in Delhi. And till date, we have covered more than 22,800 plus children. We have treated around 6,300. all these treatments have been provided inside the school premises after proper adequate care and consent being obtained from the parents. More than 350 health education sessions, more than 142 health promotive activities, and nearly 25 sessions of training, teacher training programs have been conducted. And the impact has been assessed. We have conducted 2 state level workshops among these teachers. So coming down to what we developed during this COVID time, we named it as DSHOT, the Dental School Health Orientation Training Program. So this program was actually, conceptualized when we tried to see what, because all our outreach programs were stopped, all the community services were blocked because COVID-19 had taken over completely the whole country, and we had to look into various ways how we could come up with. So one fine day when I was sitting with our consultant, Dr. Swati, and discussing the various strategies of how to look into the future of this program, we came up with this idea that why not try to see how the government schools are actually working and how are they reaching out to the, because government schools mainly are low resource areas where resource is always a key, and the children who are mainly from the lower or the middle socioeconomic background. So reaching out to them with technology might have been difficult, but we thought the teachers could be a platform through which we could interact with them. So the objective was mainly to orient and prepare teachers towards dental emergencies and oral health during COVID-19. Teachers were made responsible so that they could sensitize school children regarding oral health during this COVID-19 times. We developed a kind of a referral system through teleconsultation to target parents and children, organized health promotive events and activities, developed special targeted oral health materials for circulation through various virtual channels, and also looked into conducting research for implementing these strategies. The outcomes, as this is a pilot study, we looked at the number of teachers trained, the number of school children and parents reached out, the number of teleconsultations made by teachers and parents, and number of health awareness material developed, and the activities through various feedback mechanisms. A very strong and simple methodology was implemented, where the schools were identified, sensitized, permissions obtained, content was developed over 3 modules, and I have laid down the 3 modules. We used technology platform, which was very important. We had to check with what technology was suitable for the teachers, and accordingly we had to, because many of them didn't have access to computers, so they used mobile phones to actually attend these programs. So we did a pilot testing, and then we went on to implement this program. So these are a few photographs of what implementation we did, and you can see one of the consultant, Dr. Swati, being conducting this session. Over this last one and a half month, we have been able to train around 279 teachers. With this kind of a impact that we created, a ripple effect, as a result of which we have almost reached out to 7,500 school children and parents. We have, as of now, teleconsultation is still low. Around 49 of them have reached out to us, and we have been able to develop some videos and health promotive message, modules and material for them. And we also conducted some events, some painting events on oral health, which actually the students responded very well. Their parents were involved, and they sent in their participation through the internet, through mailing and through WhatsApp. So this is just a small project, and we look forward to actually take it further and see if we can take it further across Delhi, because Delhi has the school population, almost 950 schools are there, and we're just talking about 5 schools as of now, and we have 950 schools to cover, almost 30 lakh children studying in these schools. So we have a huge population at hand, and this pilot study, pilot project would allow us to take it even further. So we intend to integrate with the Department of Education. We trying to look at continuous feedback and look at outcomes that the teachers are providing to us, involve further stakeholders, and have more organized panel discussions wherein certain challenges could be addressed and the barriers could be come up with. Further, this is just Delhi. We're talking about 30 lakh children here, and we have a huge population of 1.38 billion. And we are looking forward to integrate with associations like the Indian Association of Public Health Dentistry, so that we can expand these services to different parts of the country and target them. So with these things in background, I would like to say that if you really want to see the change, be the change that you wish to see in the world. And with these words from our iconic freedom fighter and the father of the nation, I would like to end my talk. Thank you very much. This is our team from Maulana Azad Institute of Dental Sciences, from the department and from my mobile dental clinic team. I thank Dr. Kavita for this opportunity.
Thank you, Dr. Mohanty. That was an amazing presentation. There are many, many questions around your presentation. So first of all, there was a question asking whether, stating that in the United States, schools have been closed. So I just want to reiterate that your program is actually being delivered online, correct?
Yes, yes.
You were interacting with the students via computers and so on.
Yes.
So that was one question. Another question for you was, what kind of government support did you have to do this work? And how has that impacted your implementation and evaluation?
Okay, so in this regard, first of all, I would just like to inform everyone that this project itself, the mobile dental clinic project itself, is a 100% funded project. So we have certain objectives and we have certain strategies. And as an institution, I work for the institute, and this project is a part of my institute. So I have my director in place. We have a proper mechanism of getting approvals and utilizing the same funds which are available for this particular, there's some amount of funds have been allocated for certain innovations and technology use. So we have taken out funds from that and utilized it. We have parked it and we had kept it. So we are utilizing that. And as I told you, that this is just a small initiative that we have started now. We are looking at expanding it further with the help of Department of Education, with the Department of Health, and then expanding it to, as I told you, we have 30 lakh children in Delhi itself. And we have a huge strength of teachers available. So we intend to take it further and see how, and we have around 9 dentists with us, and we have 2 consultants. So with this human resource available, we will be taking it further and trying to see if we can get more funding for, implementing it at a larger scale.
Right. So, you and I had talked about trying to have one of the teachers participate, and unfortunately that was not possible today. But, you've done a lot of work with these teachers, and you've also done a lot of outcomes assessment, which is really quite amazing given that there's a pandemic going on and people are, feeling pulled in so many directions. But, just from the work that you have done, how are the teachers feeling about this work, and how are the families that they are targeting, responding?
Yeah. So one, as you just said, pandemic has actually struck hard everyone, and the teachers themselves are finding it very difficult because they are not provided with adequate resources to reach out to everyone. So this oral health campaign that we started actually brought out a lot of things among them. They found a new kind of energy, because till then they were all locked in houses, they don't have much interaction, and because of our frequent interaction, they started to speak out and talk to us regarding their issues, regarding issues with children, and regarding oral health concerns. So that interaction actually gave us more boost, and mainly seeing the the kind of support each one of them actually extended, we felt like we should take it even furthermore. So the teachers were very forthcoming, because at this time they were all, they didn't have anything new to look out to, because they were all at home trying to meet their deadlines with teaching and students. So this was something different for them, and they really felt very cared. Actually, I would say they felt very cared about, because someone was reaching out to them, and that actually gave us a more insight into what they were experiencing.
Dr. Mohanty, there are so many more questions that I would like to ask you, but I unfortunately see a number of questions here directed at some of the other speakers. But,
Sure.
Once again, you've done amazing work. Of course, the reality is that we can only reach these children who actually have access to computers and internet and so on. And as we try to think about those who are the hardest to reach, perhaps those who don't have computers.
Yeah.
I live in New Jersey, and I was watching on the news yesterday that in the town of Paterson, a lot of children do not have computers, and we're not sure whether children will go back to school. So there is a huge push now to get private companies to provide computers for these children. So of course, we can only do what we can do, but congratulations.
Thank you. I just wanted to add one thing here, is that actually what we did, those children who could not be reached out, we had short recorded messages on various themes that I have not included. We actually sent it across to the teacher, and the teacher had made their own classroom groups. So they would send those short messages mainly in a video format, which we had developed, which could be sent through WhatsApp, which is, you know, a kind of a messenger. So they could see and, you know, give a feedback on the basis of that also. So their parents would have phones. You know, today technology is still accessible when it comes to phones. You may not have a computer, but a smartphone is something which is there with most of them. So, you know, they use that actually.
That is very true of India. I think it's a super connected country.
Yeah, now actually.
Yes, and you know, recently at Columbia University, there was a new program that has been started with having young people develop their own outreach using TikTok. I'm not sure how long that will last, because I think it's in some kind of trouble. But
yeah, TikTok has already been banned in India right now.
Yes, but I also think your use of, you know, comics is very innovative. And
yes.
in my own work with older adults, I've often thought about comics and so on.
So we have been working on comics for quite some time. We're using the science of comic medicine actually in an intervention of promoting oral health.
So
thank you.
Thank you so much.
Yeah.
And I wanted to, Dr. Dinesh Patel, who is from Kenya and who currently lives in the US, had a question for Dr. Fine, who has answered it online, but he also wanted to hear from Dr. Mutavi about the use of allied dental health providers, so that dental services can be made available in remote regions of Kenya, including Eldoret and so on. I think Dr. Patel also wanted, in his note, he said he would like to hear from me. So Dr. Patel, just to let you know, we have been working with the University of Nairobi for quite a number of years. We have been addressing the training of community oral health workers, and I think you saw on Dr. Mutavi's slides that about 120 currently exist in Kenya. We're also working right now to develop training, program evaluation and program implementation training for county level workers, so that they can begin to include oral health in their budgets and think about how oral health can be promoted in remote counties. So Dr. Mutavi?
Yeah, thank you very much, Kavita. I think you've said a lot. Yes, I highlighted there that there are 120 community oral health officers that are registered, but there are many more who work for the public service and may not be registered necessarily, because the registration is a new thing. So we estimate there are about 1,000 community oral health officers. What tends to happen is that because of the small numbers of dental personnel, most of the community oral health officers have found themselves in clinical setting, basically relieving pain, offering extractions, and doing much more curative services rather than what was prescribed. Yeah, so they are still not so far spread to the very low levels of the healthcare system. We still have a lot of them still in the larger urban centers because of the shortage of oral health personnel. Regarding the question on whether we have tried to use nurses and other community health workers, yes, we have piloted with very many different groups. I personally have piloted with the use of nurses and part of the nursing training curricula does contain a small component of oral health. It would be enhanced, and we are looking for opportunity to be able to build more content in the training curricula of nurses, and that hasn't happened yet. But yes, it is an area that we have piloted and we are looking at. We haven't, unfortunately, really reached to work with community health care workers, because in Kenya, after devolution, there was lapses in engaging community healthcare workers. They were not being paid, and so it presented certain challenges. But we shall be working towards including a training curricula for them to be able to come on board as well. Otherwise, I think that's basically what I would like to say. Thank you very much.
Thank you, Dr. Matavi. I know that a lot of work has been done at the University of Nairobi, and while the pandemic has created a lot of problems, I think it's also brought forth quite some opportunities, as you've mentioned, and hopefully the integration of oral health and health will proceed quickly. There is a question that I would like to have all the panelists address, and this is around clinical training. I think a number of participants are asking how you will provide clinical training around dental services and soft issues like bedside manner or chairside manner. I know, Dr. Fine, that you had responded in some fashion online, but if you would like to expand.
So there's no doubt that you can do mock cases and you can do simulation. You can ask, how would you actually have treated the patient, or how would you actually have done the treatment plan? Obviously, the interaction with the patient does become a problem, as do your hand skills and your hand-eye coordination. So what we're doing right now is that we are bringing back our dental students and our graduate students slowly to have social distancing, and using our simulation laboratories for them to actually go ahead and regain those clinical skills that may have over the last 3 months fallen to the wayside. As far as soft skills, yes, they basically will have to be addressed once we have them back with a normal patient flow and interaction. And that normal patient flow is going to be phased in starting in August and slowly built up over the next several months. Once again, making sure we have proper PPE, proper infection control training, and that we can maintain social distancing between the patient, staff, and students.
Dr. Badner, any thoughts from you?
We've actually struggled with this because obviously the residents came with a particular agenda in mind, which is to get clinical training, not just in dentistry, not to be deployed. Now that we're back doing dental services much more frequently as the state opened up, we've actually added a lot of equipment into our operatories. We have filters, we have isodries, which are intraoral high-speed suctions. We have evacuators. There's an anhydrous fogger that we've added. We're not sure if it does anything, but it does provide some sense of comfort to the people. And then we give them all the PPE. So what we're trying to do is provide some semblance of improved infection prevention and provide the care in a more systematic, in a safer way than we had in the past. The good news, and the procedures are now longer on an individual patient than moving from room to room, because that becomes much harder. The good news for us is that incidence right now in New York City and in our neighborhood has come down tremendously, and we're really reducing the number of patients in the hospital, and the hospital is now half empty because people aren't coming in for their regular care. So in terms of dental care, we're able to provide dentistry, not as much as we did in last year, but with the improved infection prevention equipment, we're providing dental treatment to patients on a regular routine basis.
Thank you, Dr. Badner. Dr. Mohanty, any thoughts on?
Yeah, actually, as of now, because we are at the end of our session for this year, and we are just the examinations have been delayed as of now for the students. So maybe what has been scheduled as of now is that the examinations will be conducted each year separately with adequate social distancing measures, mainly the theory exams, and the practical exams would be actually judged upon on the previous assessments that have been carried out throughout the year. So this is for the batch which has completed the year. Moving forward, we intend to again, when it comes to the didactic lectures, that would be completely online. And when it comes to the clinical protocol, see, already we have been, as I just mentioned, a few figures regarding the patients being managed. There has been a lot of infrastructural changes that we have already done when it comes to placing exhaust fans, the HEPA 13 filters, the air proper management with positive air pressures and infection control protocols. And we are actually promoting more of 400 to 600 dentistry. But as of now, bringing back students to the clinical setup, though we have all most of the things in place and patients are being managed, but as of now, bringing students back to clinic is not yet being planned. So we are looking at somewhere between September. I think the system would be more capable of handling the students coming back, but that will be 1 month delay in our session for this year. So that's how we're looking at it. But currently, patient care is in place. We have a daily outpatient of around 120 to 140, and treatment is almost around 60 odd. We either manage medically, mostly medically, otherwise certain clinical procedures are being provided. Thank you.
Matavi, how are you planning to manage clinical training?
Well, thank you very much. Just to mention that in Kenya, obviously, we got our first case of COVID-19 in March, on March 13th, and we are still on the steep rise now. And so what we are having is basically just emergency dental services and not much else in the clinical setting. We are making a lot of preparations as well. What has been going on, we have been giving the lectures online to the students, and they really enjoyed that part of the teaching. The final year undergraduate class has actually completed the online lectures, and were due to come back for some clinical rotations and examinations. Unfortunately, I don't see that happening maybe in the next 1 month as we watch the COVID-19 experience in the country. But we are making preparations, of course, setting the clinic, acquiring the necessary personal protective equipment. We already have trained all our staff and our postgraduate students in anticipation for a possible reopening with just very few groups on campus, just to make sure we can maintain social distancing in the clinical area. We are going on with ensuring the clinical space has the correct configuration to be able to receive the students should the COVID numbers start declining. So that's where we are. We still expect that the classes will be able to complete the clinical sessions before the end of 2020. We're just busy trying to make preparations. Thank you.
Thank you. There were questions I know Dr. Fine had brought up, and also Dr. Badner, around mental health among healthcare workers, and there were questions regarding this and what your institutions are planning to do around this. So Dr. Fine and Dr. Badner, if you would take a quick stab, maybe Dr. Badner first, because your residents were at the front lines. And Dr. Matavi and Dr. Mahanti, if you would talk a little bit about.
So we were actually lucky, and it does say, perfect preparation prevents poor performance. We were lucky that we had this Helping Healers Heal program already instituted in our facilities, which meant that we had a culture and an understanding that this was part of what we were going to do. And the people involved in that program, when they recognized what we were doing, actually reached out to us saying, whether you need it or not, we're going to come to your institution and come and do a grand rounds. And they discovered that if they come and they present to the staff in public, no one actually raises their hand and says, oh, I need help. That rarely happens. But by presenting themselves and being in the room, they did tell us that privately people do take advantage of it. So one of the things we did was we brought our behavioral health care workers to our department to give either through Zoom or remotely or in a large auditorium that we have, to let people know that this was available to them. And I have no idea how many people have availed themselves of that. But I do know that people have expressed privately to me the difficulty that they felt having sent people to very difficult circumstances. And I'm hopeful that they've taken advantage of it. We've told them multiple times that they should, that they could, but I only know that we're hopeful that they would do it because we've told them that it's available.
Thank you, Dr. Badner. Dr. Fine, any thoughts?
Yes, we did two things. For those residents and faculty and staff that had to come in every single day and perform the emergency services or emergency clinic, we developed a system of having morning huddles. We met every single morning for at least 20 minutes. It started out with making sure that we were here to make sure that they were safe first in every single way, both physical safety and mental safety, and that they were always told that workhorse health and safety, which has physicians, were always available for them. For those graduate students and other staff that were not on site, our student affairs group constantly would check in one by one with the students that were not on site and provide them any emotional support or any services that they basically needed. We've still now maintained our morning huddles now as we're expanding the number of people who are coming in, and our student affairs remains highly active with all our students that are receiving their education via Zoom.
Yeah, so to go on with Dr. Fun, the huddle idea, we were also doing that. It was something that we were doing at the institution, but I in dentistry never thought was that valuable. But when this came about, we actually did that, and everybody got a chance to sort of see their team, the dental team, and sort of express the fact that they were thankful for each other as they went off to do their work and deployment. So the huddles really were quite valuable every day, wherever we were within the dental department. And I agree with what they've done at Columbia, that it really helps to feel like you're not alone, and that there is,
Absolutely.
and if we don't know the answers, but we're going to make sure that you're protected as best as we can, and then we're going to go out and do this. So that really did help, and I thank Dr. Fine for mentioning that.
Absolutely, Dr. Badner.
You know, at Columbia, they also have created virtual spaces for faculty to get together and perhaps to huddle, which I think is also very useful. We do have the chaplain of the university participating today. Unfortunately, I can't invite her to speak, but I know that there have been many efforts at the broad university level as well, just to help faculty and staff maintain some sort of sense of normalcy. Dr. Mutavi?
Thank you, Kavita. I think two levels. When COVID came around and we had to close, obviously we had to take staff through training so that they could deliver online teaching. And there was a lot of anxiety, and not just among staff, but students. And the fact that some students are in very far and remote places that they could not really keep in touch with the teaching caused quite a lot of anxiety. And what we did as a school is reactivate and make sure the mentorship committee, which works, could get in touch with the students from time to time, establish who is having difficulties, social or financial or just connectivity. And this mentorship has both staff and peer mentors that we have utilized during this time a lot. There's also the main university mentorship also came in to give some virtual lessons on how to actually make sure we can assist the students even when they are far away from where we are. But we also had a group of, we still have a group of students, the oromaxillofacial residents, who obviously have been present at the front line throughout. And the way of keeping these ones has been just to check on them from time to time and make sure that they are feeling that you're there, you can support them when they need to have a chat. And so from time to time, we schedule virtual calls and listen to their experiences. Obviously, a lot of fear occasionally when they have just managed cases that have tested positive, but so far we have not any of them actually test positive, and so far they have actually been able to just stay steady and offer services where needed. Yeah, thank you.
Thank you, Dr. Matravi. Dr. Mahanti,
Yeah,
how are
I
you
would.
addressing mental health?
Yeah, with regard to mental health, as you already clearly, most of them have mentioned, we have a way of addressing students, and we have a way of addressing the employees. So we, as I told you initially, that our response preparedness strategy was developing certain, breaking down the whole COVID preparedness into different sections, and we came up with something called as Employee Safety Committee, which mainly was developed for this COVID-19, this whole time. And their main focus was, one, to assess regularly the health status and review it. In case someone was with any symptoms, needed to mobilize their healthcare facilities. Second, with regard to mental health, so we had certain sessions, we had certain spiritual orientation sessions with tie up with certain, we had a recent session with a school of spirituality, which is mainly into practicing a few of spiritual practices in general, and they oriented the faculty and students with regard to this. So this was mainly for the faculty. We had a roster system, so not everybody would be available. 33% of them would be available on daily basis. All faculty would assemble for a like huddle system. As you said, we had a review meeting every day based on the daily patient load and discuss various issues. So that would be a kind of meeting interaction with every day with the kind of the faculty available. With regard to students, we went on to a very strategic manner. We had initially, the students were very excited to go back home because the dental school was closed. But then they realized that this is going to take some time, and so initially they were very excited. So we conducted a baseline mental assessment of the children and the students, and then went on to conducting it even further. We have conducted it thrice as of now. We have had regular, whenever the classes, the online lectures have been there, we have seen to it every before the start of every lecture, there has been a 5-minute interaction with the faculty, with the students before starting the lecture, just checking upon how the students are doing, how has been life, what are their practices. And the students were encouraged to actually engage in activities, and which kept them occupied mentally. So many of them actually sent us back paintings, they sent us back their musical videos, and that way it was very engaging to see that students were keeping themselves and then we went on. We have one of our residents who's been trained as a professional yoga expert. So we asked her to develop certain relaxation exercises with the help of yoga, and those videos were shared with these students. And also we had forward from the ministry of the yoga and the Ayush ministry, which is mainly into alternate medicine. So they shared a lot of videos with us, and which we circulated among them. And we had a student welfare officer who was regularly in touch with all this, one of the faculties who was regularly in touch with the students. So these are a few of the activities that we have conducted. I just broadly just mentioned a few of them for you.
Thank you, Dr. Mohanty. I think, you know, this has been challenging for everyone across the globe, and, you know, but it's also brought us all together in a very real way. It's made very clear that we are one globe, and, you know, that we need to learn from each other and do things collaboratively. So I would like to thank all our speakers today. This has been an amazing session. Thank you for taking the time to speak with us. Also, thank you very much to the participants today. You've had many questions. Unfortunately, we couldn't get to all of them, but most of them have been answered in the chat box. And also a very big thank you to the Columbia Global Centers Mumbai and Nairobi for always being a friend of oral health, and we look forward to more momentum in this area with you. Thank you. Good evening, good afternoon, and good morning.